Okay. Unfortunately, Sheila Patel could not make it, so we're going to move on to Dr. Danielle Lantagne, who's an associate professor in civil and environmental engineering at Tufts. She's a public health engineer with degrees from MIT and a doctorate from the London School of Hygiene and Tropical Medicine. She's also worked for the CDC and provides technical assistance and research in more than 50 countries in both development and emergency health contexts, focused on the burden of infectious diseases, and importantly, what she's going to talk about obviously this morning is water and sanitation interventions. Thank you.
Thank you, everybody, for having me. This is, I'm glad to be able to present. So I wanted to talk today about changing the narrative around water supply, sanitation, and hygiene. And we tend to have two narratives right now that we talk about. We talk about an urban high-income water narrative where we have piped, treated infrastructure that comes direct to our tap 24/7, and our children are plump and healthy and happy, and this is my son in Sierra Leone. And we tend to have a second narrative where we talk about primarily rural, low-income water and collecting from an unimproved open source, storing in a questionable storage container in the home, and then having children who are ill and having the health detrimental effects of that. And then we tend to say within these rural areas that we say we can't yet get infrastructure. We say, let's provide an improved water source, which was the goal of the Millennium Development Goals. Let's see about if the water isn't safe, if we can work with people to treat their water at the household level with chlorine or filters. Let's provide a latrine, right, for separation of waste from the environment, and then let's promote hand washing. And I think those are the two primary narratives we see within water supply, that we try to do this until we can provide 24/7 infrastructure. And I think what I'd like to talk about today is slums don't fit into either of these narratives, right? We don't have a WASH narrative for slums. And we need to move beyond this to nuance and specificity. And so for the rest of the presentation, I'd like to talk a bit about the history of WASH, some successful interventions we have right now within slums themselves, a bit on emergencies, because I do quite a bit of emergency response work, and then just a summary thought and a bit of a summary narrative about where we can move for this growing population. So probably we all know 3 types of organisms that cause diarrhea: bacteria, protozoa, viruses. At a very general level, chlorine and other disinfectants remove the bacteria and most viruses. Again, at a very general level, filtration removes bacteria and the larger protozoa. And so what we see when we talk about treating water or water supply to remove these organisms from water, we talk about combined treatment. We talk about filtration plus chlorination. And that story is what reduced infectious disease in the United States and other cities across Europe. This is a particular example of typhoid in Philadelphia. You can see population is increasing in Philly over time. This is a log scale, so you've got about 10,000 cases. You filter the drinking water that's being provided in Philly. You have a log reduction. You chlorine, you have a second log reduction. And these graphs are echoed across the US and Europe in this time period, the sanitary revolution, 1890 to about 1930, right? So for a long time, the thought and the narrative was, okay, let's replicate this. Let's put in infrastructure within these developing contexts, low-income countries. And there's huge advantages to infrastructure. It's provision of reliable quantity water. You don't have to do anything. You just turn on the tap. You have the disease reduction. You have improved hygiene, right? But infrastructure requires political stability, a large investment of public dollars. Boston's wastewater treatment plant, Deer Island, which you see when you fly in, Deer Island was $4 billion for 4 million people, and the operating costs are $300 million a year, right? Our sewage in Boston is double the cost of our water. That's the cost that we're talking about for these type of systems, right? You also need a conducive terrain, not very mountainous. You need a population density. But something else to think about is you need population stability. Your population can't be growing too fast or decreasing. And you also need land tenure. You need space to put these things in. And these are particular requirements that in many slums are very difficult to meet, right? And so when we talk about the population increases in kind of cities right now, I wanted to show one image. This is Shanghai in 1990 and 2010. So what we're seeing is the urbanization that's happening right now in cities is happening in a much increased rate. Like London urbanized over about 50 years, from 1 million to about 6-7 million, which is roughly where it is today, give or take, from 1850 to 1900. There was time to catch up to that growth. We don't see the time to catch up to this growth that's happening in the cities in Asia and Africa, because they're urbanizing from 1 million to 10 million people in 20 years. Right? And so putting in this hard infrastructure is very difficult. China's managing it because they have a top-down centralized scientific approach, and they're rolling out water and wastewater treatment plants on a daily basis, and they're all the same, right? Now, this is one thing. But in other places, and in particularly I wanted to focus a bit on Sub-Saharan Africa, what we see, the countries not in blue, back up. I'm learning this. Okay, the countries that are not in blue here, the orange, yellow, gray is they're not reporting. These are the countries that did not meet the MDG for water. These are the countries that didn't reduce in half those without access to safe water and sanitation. And then this is the percent over here of the population in cities that lives in slum. That's the red. So you're looking about some contexts where 75 to 90% of the population in the cities are living in slums with unknown land tenure. And so these are places where what China is able to do right now in rolling out water and wastewater treatment for very rapidly growing populations, right now that's not yet possible in a lot of these places. And so then we come back to this question, what do we do until these populations can have the reliable infrastructure? And so that was a bit of the introduction. I'd like to go through 3 or 4 specific examples of WASH programming in slums that has been working, right? So one of the huge successes we're seeing in water supply right now is kiosks. These are commercial sector, not externally funded. They're coming up on their own in the commercial sector. They tend to be centrally treated water that's trucked and then stored in a tank. And all that the kiosk is a storefront to provide people 5 gallons, 20 liters of water. You purchase by container. These are popping up Haiti, Indonesia, across Africa. CDC recently conducted a study looking at them in Port-au-Prince, Haiti. They found 1,300 of these in a small block. Over half had been opened in the last year. And they kind of came down to about 4 large providers. They were franchised off of 4 large providers. And over 90% met World Health Organization E. coli guidelines when they were delivering safe water at the kiosk. So there's some questions about what to do with these, and those questions really are, what's the role of recontamination in households? Is that water going to be safe throughout the storage chain? And what's the role of external funding? How can external funding kind of leverage to increase the safety of this water, increase regulation of the government, and also think about how do we follow that water and to ensure it's safe throughout the entire water chain, right? So, but this has been kind of, I've watched this pop up in the last 5 years across countries, and it's been really interesting. If we talk about the second stage, so we talk about water supply, water treatment, sanitation, and hygiene, right? When we talk about water treatment, ideally water is treated centrally. You don't have to think about it. It comes to you and you don't do anything to it. That doesn't always happen, and we can treat it at the point of collection or at the point of use. As you move up that chain, ideally it would be centralized. You have decreasing behavior change needed. If you're treating your own water, you have more behavior change you have to do at the household or at the community level, right? And so an example from point of use, water treatment that we have seen success in urban and rural areas of Haiti that were affected by the earthquake and cholera. This is a locally branded safe storage container with a tap and then a liquid chlorine solution. This was distributed with community health workers, much of what the previous speaker was talking about, community health workers support and household visits to families. And what we see is a bit of sustainability. This is chlorine residual in household drinking water. And in 2010, at the height of the cholera, you see about 3/4 of households reached with this program. It's about kind of on the order of 15 to 20,000 households being reached, right? 3/4 of them have chlorine residual in their drinking water. 4 years later, about half. There's a drop in sustainability, but with those community outreach, with appropriate products, you can get use, but you need a lot of training and you need a lot of community health workers. It's difficult to scale, but there is some potential here. If we talk about point of collection, this is a program called Dispensers, and it's a tank of chlorine that sits next to a source of water. And so when you go, it's supposed to minimize the behavior change a bit. You go collect your water, you put a shot of chlorine, and you come home. We evaluated this in 4 emergency contexts, and what I'd like to point out is how important context and implementation is. These are the results. I don't need you to focus on them specifically or notice individual numbers, but what I want you to focus on is 2 countries had almost no use, and 1 country had almost 100% use. And that all was due to a set of implementation factors we teased out in quantitative and qualitative analysis, including having experienced staff, having appropriate training, having materials in the right language, making sure the dispenser's engineering didn't break, et cetera, et cetera. And so the same intervention, one of the things we often say in WASH is there's no silver bullet intervention. There's going to be an intervention appropriate for the context that needs to be well implemented, right? And so this is the sense of, I just kind of wanted to show you that there can be the same intervention with very different results, depending on implementation quality. So that was the water treatment side. And then I wanted to talk about sanitation as well. And here we defecate, we flush the toilet, it goes to a treatment plant, and it goes away. Ideally, what humans want is not to deal with their own sanitation. They want it to go away, right? And in the United States, it's actually kind of idiotic that we take nutrients and we put it in very clean water. We have nutrients from the urine and then the feces with all the infectious material, and we put that in very clean water, and we spend a lot of money to ship it away, right? And then it's very difficult to treat because you have to separate everything out to treat it. So when we talk about kind of sanitation, when we're not in a sewage system, we talk about the sanitation chain of collection, of treatment, and of reuse, right? And I want to give an example. This is a program in Kenya, in Kibera, that is they do, you pay, and then these are central facilities where you go to defecate, right? So they're called Fresh Life. They're central facilities, you defecate in a bucket, and then from those sanitation facilities, they collect those buckets, they truck it, they have a waste facility treatment plant, and then they actually use it for agricultural reuse and for a little bit of electricity generation. So this is thinking about sanitation and waste as having potential for actual either electricity or as nutrients and recovering those nutrients. So this is one program where you go to a special toilet in order to defecate, and you may pay for that. This is a service that's provided. Another program also in Kenya is called Sanivation, and they have a slightly different model where they have customer-oriented waste collection. They actually provide people who sign up for their program a kind of toilet in the home, and then they come to the home and they pick up that bucket on a regular basis. They then treat it using UV and heat, and then they actually turn that into briquettes and they sell that for cooking. One of the best Christmas gifts I ever got my mom was they have a fundraiser called a stocking full of shit, and they give you a red stocking and some of these briquettes, and I got that for my mom one Christmas. She didn't appreciate it. So this is you can see a slightly different model, but again, this kind of thinking of the sanitation chain. And the last thing I want to do is a little focus on Syria. So we worked with the WASH cluster in the Syria response. They've collected data. Syria was a country that in 2009, greater than 95% of the population had access to pipe-treated, safe drinking water and sanitation. With the conflict, as you can see from the data, the network water is declining rapidly. Even between the data collected in 2016 and 2017, we see 7% drop. Now it's at 15% in 2017. This varies by sub-district. Oh, sorry. This varies by sub-district, the data down here, depending on what side of the conflict you're on. But there's deliberate targeting in the destruction of infrastructure in some areas. The trucked water network is private. It's come up, they sell water, it's provided. The majority of the population is now depending on this, and the intervention that is being worked on is to try and get that water safe, right? To UNICEF providing chlorine to get that into the trucked water so that that's safe water that's being delivered. Yep. And so I think one of the things here is thinking really about what is the entree point to help, right? And in this case, UNICEF, it was getting the chlorine in, because it's hard to get chlorine over the border. So to sum all of this up about what I've said, we need to move beyond these exist washing narratives to reach those in slums and focus on thinking about decentralized wash services, ones without the hard infrastructure. We need to provide the necessary training and education to the people implementing the program, to the recipients, and we need to really think about supporting the private sector. There's a lot of private sector initiatives, particularly within water, more so than in sanitation, that we can kind of leverage in order to reach the scale that's needed. And really, we've got questions about decision-making. What do we enter with? And what's the sustainability that we have? How do we make these programs sustainable over time? And then the larger question, how do we get infrastructure into these contexts in the long term? But the health is happening now, and we have to focus on the short term and the long term. And I wanted to say thank you for having me, and I'm happy to take questions after we're done. Okay, thank you.